All right, good morning. So I introduced myself before we started recording, but for those of you that just joined, I'm Gail Osborne, the Executive Director of Foster Family Alliance, and we are the parent association for foster, adoptive, and kinship families. So we serve in any capacity to support, train, advocate for families. And so feel free to reach out to me with any concerns, any asks, or anything like that. And I'll drop my email in the chat towards the end. But I'm going to hush because I promise you that this will be one of the most eye-opening conversations that you've had in a long time. When we first connected with Dr. Bird, I had like 6 pages of notes in our probably 30-minute conversation. I kept writing it down. I just couldn't get enough. And I was like, we have to get him to our summit, our Teaming with Team Summit. And so let me just introduce him, and then I'm going to turn it over to you, Dr. Bird. So he's joining us from North Dakota. He is a professor in the Department of Pediatrics. He is the director of Fetal Alcohol Syndrome Center there and the University of North Dakota School of Medicine. He's been there since 1980. That was a few years after I was born, by the way. And it's just amazing the work they're doing there and what they can share with us, and just totally changing my mindset and how I interact with my children. So Dr. Bird, it's your turn.
Thank you. Well, if you'll put up the PowerPoints.
Absolutely.
So the way I'm going to lay this talk out is, first we'll just have some general comments about fetal alcohol spectrum disorder. Some things you may know, some you may not. And then we will have a more specific look at the developmental trajectories of fetal alcohol spectrum disorders, leading us into adolescents and young adults. Then we'll spend some time talking about that population, particular concerns they have, and how we might organize our thinking around helping them. So on the first slide here, one of the things I want to point out is that the cause of fetal alcohol spectrum disorders is alcohol use during pregnancy by women. Alcohol use during pregnancy can be quite harmful. And one thing you can do to make it even more harmful is to smoke while you're drinking. So smoking, alcohol use have multiplicative risk factors. So when you drink and smoke, you have this huge increase in risk. So just as a first step here, when you identify moms with this kind of difficulty, if we can't get them to quit drinking, we should try to get them to quit smoking, because the risk reduction from that is huge. That takes away more than half of the risk. So very important to keep in mind that we have a couple of ways we can intervene here, and we need to remember to do that. Next slide. Everywhere I go, I hear a similar set of concerns. If it's from the medical community, from foster care, from special education, and there's a persistent belief. Many women drink during pregnancy, but not the ones I see. Pediatricians, family medicine doctors often think that asking about drinking, child visits may complicate their relationship with the mom. Widespread belief drugs are a bigger problem here. I hear a lot of people who obviously don't understand much about FASD saying, look, we're already doing everything that can be done. what's the point in diagnosing FASD? And a thing that's just cropping up now, and if there's some sociologists here, anthropologists, I'd be interested to know if this is a alcohol industry sponsored endeavor. Fetal alcohol spectrum disorder is just too much stigma. Too much stigma for the mother, too much stigma for the child. And so I'm not sure how to respond to something like this. If you die from having FASD and it's undiagnosed, do you have less stigma? If you go to jail because you have FASD, if it's undiagnosed, does that reduce the complexity of that? So I'm very skeptical of this FASD initiative dealing with stigma. There is a lot of stigma. There's a lot of stigma if you have leukemia. There's a lot of stigma if you have ringworm. There's a lot of stigma if you have autism. A lot of stigma if you have intellectual disability. And I think FASD has a significant amount of stigma itself. But these are the cards we're dealt. And we have to recognize that and be able to go ahead. Next slide. So what about North Carolina and alcohol use? Do you guys only use drugs in North Carolina? Well, I think in North Carolina, alcohol use is very common, has not decreased, often occurs with other substance use, particularly opioids, cocaine, those kind of substances. One of the things that's really worth contemplating is that as we put more and more money into education and prevention, trying to educate more moms, more young women about the adverse consequences of drinking during pregnancy, the numbers of women who drink during pregnancy continue to rise. So that's worth reflecting on. How is it that such an obviously straightforward message is getting lost and muddled? Next slide. Let's have a look at North Carolina. So you guys do have an occasional cocktail there. In 2020, you had sales, I think, of $1.3 billion. In 2021, that went up to $1.5 billion. That's a 16% increase. And I don't know where you're at for 2022. But I suspect this is steadily going to increase because, as I mentioned, there used to be a huge gap between the number of men who drank and the number of women who drank. Now, women's drinking is increasing at a faster rate than men, so they're closing that gap. Next slide. So I see quite a few kids in foster care, quite a few kids who are adopted. And one of the things I've noticed is that when people hear a report, well, mom used meth during pregnancy, their mind kind of goes blank. What could possibly be worse than using methamphetamine? Another thing, to keep in mind is that for reasons that escape me, women are much more willing to report drug use than alcohol use.
Mhm.
Mothers rarely, and I mean rarely, volunteer information about drinking. This is complicated by the fact that at every step in our healthcare system, people are reluctant to talk about these problems. So a very illustrative example of this is that in 2 hospitals in North Dakota, we have demonstrated that when you go to the emergency room, no matter what the cause, taken by the police, dropped off by ambulance, your mother brings you in, however you get there, pregnant women are screened for drug and alcohol use 25 to 40% less frequently than non-pregnant women. So because many pregnant women are transferred from the emergency room up to obstetrics for care, we had assumed that they were doing the heavy lifting up there. But rates of concern about this are even lower in an obstetrical setting. Next slide. So here's the problem. In North Carolina, you have a large number of women who are drinking prior to pregnancy. They drink during the first part of pregnancy. A substantial number of them continue to drink throughout pregnancy. Drinking causes brain damage. The brain on the bottom is an animal that was given saline, which is essentially water. The brain on the top is the animal that was given a single dose of alcohol. And all of the dark shading are cells that are in the process of dying from a single exposure to alcohol. So a take-home point here might be that during pregnancy, every episode of drinking is an episode of brain damage. Prenatal alcohol exposure mostly shows up as impairments in brain function. So let me just step back from that a second. So we know, for example, that drinking during pregnancy increases the risk of miscarriage, increases the risk of stillbirth, increases the risk of newborn mortality, increases the risk of death from infectious illness, increases the risk of sudden infant death syndrome, and has a long-term effect on mortality of increasing risk of death fourfold. So prenatal alcohol exposure, the way we have most states configured right now, we're interested in those pregnancies and babies, young children who have lived long enough to get to the diagnostic process. All of those who died earlier are not going to be counted as having a fetal alcohol spectrum disorder. And so we're missing quite a substantial number of children. So a second pretty helpful point for you is that we want the diagnosis at the earliest possible time. I'm trying to correct in myself and the trainees we have in our clinic a really bad habit we've developed over 20 years of seeing babies, toddlers, young children who it's clear have fetal alcohol spectrum disorder. And we say, well, we're not going to diagnose it right away. We're going to wait. While we're waiting, enormous damage takes place. And so we're trying to change how we approach that and quit doing it. A diagnosis of fetal alcohol spectrum disorder predicts the things on this sign. High rates of abuse and neglect. High rates of mental disorders, school problems, legal problems, substance abuse, and inability to live independently. In addition, and I'll come to this again, fetal alcohol spectrum disorders mostly show up in the foster care system. Most foster care settings, I wouldn't say they refuse to acknowledge this, but they're very reluctant to acknowledge this. So early diagnosis means that we can focus on these problems and try to prevent them. That is an extremely important goal. So a diagnosis of fetal alcohol spectrum disorder is going to lead to diagnosis-informed care. We're going to do something different because this person has fetal alcohol spectrum disorder. This is one of the things we have to get across to early intervention providers, social workers in foster care, foster parents, adoptive parents, pediatricians, psychologists, speech pathologists, occupational therapists, preschool teachers, elementary school teachers, on and on and on it goes. We have to get people to recognize that when fetal alcohol spectrum disorder is diagnosed, we have to do something different. And much of our emphasis on this sign, we want to prevent this stuff. And we have to start early to prevent this. Next slide. So I've spent a lot of time studying FASD around the world. We have data from 41 different countries. And worldwide, out of every 800 people with an FASD, only 3 ever get tested. Only 1 will get diagnosed. How is it in the United States? I think a little better, maybe. We might be diagnosing possibly in some states around 1, possibly 2%. I don't believe, to my knowledge, there's any state that could reasonably make the claim that they have diagnosed 5%. So the overwhelming majority of people with FASD, whether you're talking in the delivery room, in the neonatal intensive care nursery, doing well child visits, in foster care, in early intervention, in preschool, in elementary school, in residential care, in substance abuse treatment, in juvenile corrections, the mental health system. Virtually all of these cases are undiagnosed. And it takes quite a bit of reflection for people to realize that when I ask them, have you seen many children with FASD? They say no. And then you can reassure them that many children with FASD have seen them. And this requires a change in the way we approach this problem. Next slide. So before I touch on this, I want to just share a couple of stats with you. I didn't really write these down because I think these stats tend to put the mind to sleep. And so North Carolina has about 118,000 births a year. If the prevalence of FASD is 1%, that means that you have 1,187 new cases every year. That's 3 a day, 21 a week. So I'm perfectly confident that your state has no capacity to diagnose 21 children a week with FASD. If the prevalence is 5%, and a pretty famous resident of North Carolina, a guy named Philip May, has done a series of studies on FASD, demonstrating that in first grade students in middle class schools in America, the prevalence is around 5%. So if that's true, every year in North Carolina, you have 5,939 new cases, 16 a day, 112 a week. And I wouldn't be surprised if somewhere around 100 to 150 is your state's entire capacity to diagnose FASD. They might do 150 new cases a year. It's not being critical either, because many states don't even have remotely that kind of capacity. 2 more numbers for you. Teens and young adults. In the population 13 through 21, if the prevalence is 1%, you have 10,683 people with FASD. It would take decades to diagnose all of them. If it's 5%, North Carolina has 53,415 cases of FASD.
Dr. Bird,
Yep.
we have a question in the chat. And I think it's really relevant what you're talking about. Is there any age when it's too late to diagnose?
No, we've diagnosed a woman who was 81. She diagnosed herself and came to see us. She diagnosed herself at 70 something and came to see us to get it confirmed. She wrote back a letter talking about how it changed her life. She put a couple paragraphs in the letter talking about how she wished she had known when she was younger, so she could have prevented all the babies dying from FAS. All her brothers and sisters who died from liver disease. Many people in her family have died from complications of alcoholism. So no, I don't think it's too late. So if it's 5%, you have 53,415 people with FASD. Now I want to make a point here. Although these people are undiagnosed, they're not unserved. They are in special education. They are in foster care. They are in juvenile corrections. They are in your mental health systems. They're being adopted. They're being sent off for residential care. They're consuming huge amounts of money for birth defects and other health problems. But in all cases, they're being treated for the wrong thing. And it should be clear that it's not cheaper to treat people for the wrong thing. You don't save money by not having these people diagnosed. You don't save money by not having them get diagnosis-informed services. What about FASD? Well, think of this for a minute. In North Carolina, in the United States, most of the Western world, fetal alcohol spectrum disorder is the leading identifiable cause of intellectual disability. Should children with intellectual disability be routinely screened for FASD? Yes, because it's the most common cause of intellectual disability. It's the most common cause of mental disorders in children. Depression, anxiety, on and on they go. 50% of people with FASD have attention deficit hyperactivity disorder. FASD is a leading cause of placement in residential care, the cause for a substantial number of people entering juvenile corrections. If we reconfigured our criteria for developmental disability to allow these kids to get in, would be by far the most common cause of placement in developmental disabilities. And FASD is a huge cause of learning disabilities. Why is this? Well, because drinking during pregnancy causes brain damage. Brain damage looks like this. So it's going to take a while for our systems of care to catch up with this data. It's going to take a while for our universities and training programs to catch up with this data. Next slide. More of the similar stuff. FASD, leading cause of placement in childcare, childhood mortality, outpatient mental health visits, inpatient psychiatric hospitalizations, special ed placements, visual impairment, and impairments in adaptive behavior, which lead a lot of people into the juvenile correction system and make it difficult for people to live independently as adults. By the way, here are two children from our state who both have FASD. These children demonstrate two important issues. FASD recurs in families. When we pretend that alcohol is not a problem, we don't ask about this, many of these moms will go on and have another child and another child and another child. Recurrence is preventable. Next slide. A key concept that we have to get across to people, this is true of social workers, early intervention, preschool teachers, adoptive parents, biologic parents, pediatricians, psychologists, psychiatrists, pediatric neurologists, speech pathologists, occupational therapists, physical therapists, and on and on and on and on. What we have now is a disorder which tends to increase in complexity over time. So if you're getting advice from someone that let's just wait because I think they'll grow out of this, that's extremely bad advice for FASD. Because the trend is just exactly the opposite. It tends to become more difficult over time. The gray area that you can see here is the amount of excess disability children have from not being diagnosed and not receiving diagnosis-informed care. So when someone tells you, well, I really don't see the point in that because what would they do differently? We're already doing everything that could be done. This should alarm you and should go seek help right away. Because it's pretty clear this person does not understand FASD. It tends to become more complex over time, especially if it's undiagnosed. If you look along the bottom, you can see that this period of postnatal adaptation, followed by childhood developmental disorders, sleep problems, delayed milestones, needs speech, lots of temper tantrums last for a long time. It's then followed by this period of adjustment problems and adolescence. That's followed by adaptive behavior problems for adults. Could this person live in an apartment by themselves? Probably not. Somebody's to end up with all their money. They're very vulnerable and gullible as a group. Now, can they live in an apartment with perhaps a moderate amount of help? Different story. Much more likely to be successful at that. As adult life continues, FASD becomes a condition of chronic disease. Somebody told me once that I need to figure out a way to make FASD more positive. This is just too much for parents. And I've thought about that and decided that that's really poor advice, and I'm not going to do it. Because these are the facts. And although it might be tough to hear when your child's at 4 that they're at risk for school problems, that you need to begin to think now about substance abuse problems and behavior difficulties, impairments that might land them in the criminal justice system. If you do that, you dramatically reduce their risk for these problems. If you don't do it, you increase their risk for these problems. So other people will become the conveyors of happy news about FASD. I'm not that person. Next slide. The goal of diagnosis-informed interventions is to whack out this excess disability. A lot of this is not that complicated, right? Undiagnosed and being placed in 31 different foster homes is unlikely to help you do well as an adolescent and adult. Diagnosed and placed in very high resource homes with a lot of respite care, very likely will prevent many of these subsequent placements, dramatically reduce excess disability. Next slide. Should come as no surprise to us, FASD is expensive. So in the United States, a child with FASD costs an additional $20,000 a year. An adult with FASD costs an additional $23,000 a year. If you look at the full range of their costs, including the burden on caregivers, sometimes one person has to quit working, so there'll always be somebody there. People can't have complicated jobs because you're always going to OT or speech or PT or to see the psychiatrist or the psychologist for therapy. In general, we use a figure called time to a million in North Dakota. And by the time a person's a little over 18, we have spent over $1 million taking care of them. That's an excess cost, right? Excess cost. So it's a very expensive problem. If we can get rid of about half of this excess disability, we're going to save a boatload of money. This would be true in North Carolina as well. Next slide. Our current estimates FASD is about 26% more expensive than ADHD, 26% more expensive than autism, a lot more expensive than asthma, more expensive than diabetes, about 50% higher than caring for someone with epilepsy. So all systems of care are impacted by people with FASD, most of whom are showing up there without a diagnosis. Next slide. How about a simple way to identify people who might be at risk for FASD? If you have a sibling diagnosed, if you're in foster care, if your mother's in substance abuse treatment, if your mother's dead, missing, in jail or prison, or if you've had a positive screen for drugs as a newborn. Now, important to realize that many places screen for drugs, but almost no places screen for alcohol use in newborns. I want to just talk about number 4 for a second. We have a big push for the past few years on women's health, especially young women of childbearing age. So if we take two women, oh, something happened to our, we're going the wrong way. There we go. We're on number 4. If we take two women, the same age, pretty much everything else is the same about them. Woman A delivers a baby. Woman B delivers a baby who is subsequently diagnosed with FASD. The mother of the child with FASD is 44 times more likely to die than the other mother. So a diagnosis of FASD is a huge mortality indicator for the mother. So somebody needs to go find her, try to get her into treatment, see if we can save her life. Next slide. So we talked about this, right? Drinking and smoking, much worse. Each episode of drinking during pregnancy, episode of brain damage. This brain damage produces impairments. We looked at all these impairments, big list of them. These affect development. They increase your risk for abuse and neglect, developmental mental disorders, school problems, legal problems, huge increase in risk for substance use, and decrease your ability to live independently. Make it much more likely that you're going to have a significant amount of assistance as an adult. Next slide. So let's back up a little bit and see how we get to where we're at now. Who goes into foster care? Imagine we had 2 doors. One door for children going into foster care where in the family there was no substance use, no drug or alcohol problems for either parent. That door hardly ever opens. The other door, where parents come into foster care, children come into foster care, where there are drug and alcohol problems, the predominant reason you go into foster care is substance use. Now, I'm not denying that there is at times somebody who has a extremely violent temper, perversions, other problems that place children in foster care. But the overwhelming majority of children enter foster care because substance use is so severe that when the social workers from child protection go out to visit, they cannot find a single responsible adult so that they can say, yes, it might not be ideal, but it's safe for this child to live here. Next slide. So I just want to get this across because it's extremely clear. This is not like it's an argumentative point. Foster care is a substance abuse treatment program. They need to recognize this. Especially, I'll tell you who needs to recognize this, are the judges. This is a fundamental failure when judges aren't asking that every child coming into dependency court, I don't know what it's called in North Carolina, child in need of protection, whatever it is. All of these children need to be screened for FASD. Because without it, we are in substantial part treating everybody here for the wrong thing. Next slide. I think pretty much everybody involved in this knows this, right? You're incarcerated in the juvenile correction system because you're very difficult. You tend not to learn from experience. You keep doing the same thing over and over again. We use juvenile corrections because it takes too long to get you diagnosed with FASD. And we have pretty much unlimited capacity in those settings, right? The FASD clinic closes on weekends. It's closed over holidays. They close at 5 o'clock. The correction system, 24 hours a day, 7 days a week, they're open. You need 4 police cars on Christmas Day, they'll send them. The FASD clinic closed. So we need to begin to get into these systems of care and bring about some fundamental change. We should not be using these systems of care to care for people who have developmental disabilities. And remember, FASD is a developmental disability, and it's the manifestation of this disability. The poor judgment, inability to learn from experience, being naive and gullible. It's the manifestation of this disability that gets you incarcerated. Now, we could do that for people who have visual impairment, but we don't. Because we realize that's a completely incorrect way of taking care of them. Next slide. So I want to get back to this point. Drinking during pregnancy causes brain damage. No 13-year-old who can't control their temper, who has attentional problems, severe memory impairments, planned this out and said, well, in the 4th month of pregnancy, I'm going to get my mom to drink a lot so I can have a lifelong disability. Children with FASD were born with this brain damage. It changes over time. They cannot make it go away. when you're dealing with brain damage, a significant part of our intervention has to involve accommodations. In FASD, many people have vision problems. So could we run a behavior program to make people see better? No. What we've done instead is we've said, look, we identify these children with vision problems. We're going to accommodate for this with glasses, some other accommodations, and they do much better. The vision problem remains, but our accommodations improve their performance. This is what we're going to do with speech and language problems, with memory, with poor judgment. We're going to do accommodations. That's diagnosis-informed care. That's an intervention with an outcome, a positive outcome. Next slide. So we've already talked about this. Drinking leads to brain damage, leads to impairment. These impairments look like this stuff. Cognitive impairment, sometimes intellectual disability, learning disability, substance abuse, judgment problems, chronic illness, depression, anxiety. This is what FASD looks like. Nobody cares about the facial features of FASD. Those are irrelevant. Nobody ends up in juvenile corrections because you have an upturned nose or a thin upper lip. Focus on facial features decreases the likelihood of you getting a diagnosis. Because most kids with FASD don't have facial features and growth impairments. We need two tracks. The overwhelming majority of these people need to go to a track where we're understanding alcohol exposure during pregnancy and the outcomes. And then a tiny number of them need to get trotted over to genetics, places like that. 2-3% maybe. Genetics getting clogged up with these people. They have no expertise in doing this. We should be trying to get them out of there. This is the expertise of psychologists, psychiatrists, neurologists, special ed teachers, speech pathologists, applied behavior analysis people, developmental disabilities. So when we're running all these people through a genetics clinic, fantastic waste of money. Slows down your chance of getting a diagnosis. You're seeing people who have limited expertise in what's wrong with you. So, next slide. One of the great statistics ever presented for FASD. Canada, the United States, reasonably similar. So in Canada, if you have FASD, you're 19 times more likely to end up in our juvenile correction system. What parent should not know this when their children are young? The social workers need to know this. The foster parents need to know this. Definitely the adoptive parents need to know this. The schools need to know this. The psychiatrists, the neurologists, your mental health system need to know this. Because we don't want these kids going into the correction system. This is just more evidence of us using interventions which are not diagnosis informed. Now, I'm not saying that some children and adults with FASD don't need the correction system. Sure, there are some, but the overwhelming majority of these people are not helped by being in these systems, except that many times this is the system of care which has the most resources. How crazy is that? So, very high risk. We need to know this early and begin to think about it and prevent it. It's ridiculous for these kids to be going into a juvenile court and people acting like somebody with brain damage has behavior problems. This is a fundamental obligation of a judge. Next slide. When these babies are born, people run around the hospital saying, "Oh, have you seen that little baby? They were exposed to drugs or alcohol or whatever. Oh, they're having such a hard time." There's so much empathy for them. There's so much anger towards the mother. Well, this empathy only lasts for a while. When this 15-year-old breaks into 50 cars, we say, well, we know that your brain is anatomically abnormal. You have these functional deficits, these impairments, but we don't care. You must be responsible for your actions. They could take away their glasses, hearing aids, medication at the same time. So this is the same brain damage this baby had, present now in this adolescent young adult. They cannot make it go away. They had nothing to do with their parents drinking. They had no control over that. Next slide. These guys in Florida. Wow. How about this, huh? Florida Supreme Court. We can envision few things more certainly beyond one's control than the drinking habits of a parent, prior to one's birth. We need a plaque, big plaque. In all residential care facilities, all juvenile corrections programs, reminding people of this. These kids did not cause their disabilities, their impairments. They cannot make them go away. We can make them much better if we recognize them and we accommodate for them. Next slide. So I think I've made this point, but this is a systemic problem in the criminal justice system. It's a systemic problem in the dependency court system, starting with infants. Next slide. One of the reasons we don't want these kids, these young adults, anybody with FASD in these systems, they are incredibly gullible. They are vulnerable. They are relentlessly exploited. Almost half of juveniles in correction system have given a false confession. Some of these are outrageous confessions. So obviously the result of systematic coaching during interrogation. These are outrageous confessions. They should not be in there. If they're in there, one of the obligations of these systems needs to be to get these people diagnosed so they understand what they're dealing with. Because otherwise they're going to be in there a long time, keep coming back, coming back, coming back. And it's an inappropriate system of care for the majority of people. Next slide. FASD is a concern at every level of contact with the legal system. Pre-arrest, interrogation, court, sentencing, incarceration, parole, and probation. Every level. I'll give you two examples, help you understand this. People with FASD have 10 times the risk of anxiety of people who don't have it. People with FASD highly likely to have problems with gullibility. I'm on your side. I just want to figure this out so you can go home. We need to work on this together and figure this out. Tell me your side of this story. They're extremely vulnerable to confabulation. The process of interrogation interjects all these facts, which people with FASD then remember. They remember things that are untrue. They remember things that were suggested. Confabulation. So at every step along here, FASD presents a problem. Defense attorneys have got to get up to speed on this. Next slide.
There's one question, Dr. Bird, about like specific counties and identifications of FASD cases. Like you have the statewide projection, but is there any way for counties to be looked at for the stats?
Sure. Crudely, you can say, how many births do we have in this county? Take 1% of them. That's the low end estimate. Multiply that by 5. That's the higher end estimate. So 1% is a 1% prevalence rate. 5% is a 5% prevalence rate. That'll give you some idea of how many folks you might have each year. Multiply that times 18. You'll know the number of cases you have birth through 18. Next slide. Sort of 11 keys to thinking about incarceration: gullibility, naivete, credulity, suggestibility, confabulation, anxiety, low IQ, impulsivity, poor comprehension, memory problems. The 11th is all those with the star by them, asterisk, whatever you call that thing, are part of a FASD specific neuro-linguistic or language disorder. So people with FASD interact very poorly with the juvenile corrections and criminal justice system. And where possible, we should keep them out of there. Next slide. Just to remind you again how we get here. This person had no control over their mother's drinking. FASD is a lifelong condition. If we don't identify it early and do some things to prevent it, maybe it's about 50% more severe than it should be. When these kids start getting older, we're no longer interested in brain damage, no longer interested in impairments. We want accountability. This leads to incarceration. Knowledge of this incarceration should start impacting the way we care for these people very early in life. Next slide. Here's a way to think about this. These kids first walk into the office, we're thinking, well, look, they got behavior problems and they got some impairments, right? They got a visual impairment, maybe they got some learning impairments. They got behavior problems. They won't go to bed. They wake up in the middle of the night. They have temper tantrums. They're hyperactive as a lizard. And when we sit down and do this assessment, what we find: less behavior, more impairment. This is the fundamental thing of diagnosis-informed care. Less behavior, more impairment. Behavior problems, we're going to try to change. Impairment problems, we're going to mostly accommodate for them. Fundamental principle of intervention. Next slide. A lot of information on here, but why diagnose FASD and how could it help? Well, it identifies the cause. It tells us a mother who has a huge health problem and untreated is likely to have additional affected children. Identifies a SIBSHEP, a family where everybody is at hugely increased risk for FASD. Identifies children who need a particular intervention. I've listed that intervention in number 6. Mortality reduction. We don't want these children having 8 or 10 adverse childhood experiences. We don't want them having multiple foster home placements, 5 years of school failure, development of substance use disorders, ending up in corrections, being repeatedly victimized and exploited, and we don't want years where they're being treated for the wrong condition. How could we fix that? Next slide. Yes, you can. Next slide. This tool functions well for 2 things. Screening, 3 years of age and older, all the way into the elderly. You down here and you put a check in this column. The professional person doing this, very important, the professional person doing this then adds conditions they have observed, they're aware of, that the parents, the caretakers did not check. You total that up, you got 2 cutoffs at the bottom, 16 for 3 through 6-year-old kids, 20 or above for 7-year-olds and up. Takes 10, 11 minutes to do this. A little bit of training. Very important that you have somebody that knows this child well enough to supplement the parents, foster parents, whoever the caretaker is, that score. And you have a screening done. So after 15 years of doing this, it's come to our attention that these form 2 excellent cut points for a diagnosis. So you come to see us, this is perhaps one of our main diagnostic tools. So in North Carolina, you can do this. The mental health system, the foster care system, the juvenile correction systems, you can do this. How do we translate this into an action plan? It comes with a computer scoring program. Next slide. Oh, these are some of the areas that it focuses on. Next slide. There we go. We went through a couple. There's a couple other slides there that may be informative, but oops. This looks at 5 broad areas and the domains that are in the ovals. Produces risk scores for these. Next slide. This is what the printout looks like. I'm going to start at the top where it says clinically significant. The computer will put a check mark by every one of these areas that is significant. It's pointing out to you areas that you should be paying attention to in thinking about this particular person. On the right side, you see these bars. So here are the specific areas that you're going to focus on. And obviously, the higher the bar, the more important the emphasis. Now, I'm not sure I agree with our students. Who call this the mini neuropsych. But how good is this? Well, it's 78% better than nothing. I made that number up. So compared to no information, this is going to be extremely helpful for you in capturing deficits and impairments that you want to acknowledge and consider in your intervention plan. Let me check the time here. Oh, yeah. So if there's questions about this, we'll just kick them to the end and you can bring them up. Next slide. This is a couple of topical areas dealing with these impairments. Gives you a little definition of what they are, some guidance on how you might think about these things. So these are a set of neurocognitive dimensions caused by brain damage. They're typically not well considered in most assessments. And I think that's unfortunate because these are a key. Next slide. I do have a couple thoughts on environmental factors. Very important in thinking about this to realize the sequence of exposures. Children with FASD are born with the brain damage caused by prenatal alcohol exposure. They're born with it. In general, adverse childhood experiences are postnatal exposures. Now, there's some argument about that, but just in general, postnatal exposures. If you have a child with FASD, in general, the prenatal alcohol exposure caused so much damage that the adverse childhood experiences in that population are not nearly as important as they are in children who don't have prenatal alcohol exposure. So I did not say that they're not important. But from a technical standpoint, much of the variance and outcome is accounted for by the prenatal alcohol exposure, not by the adverse childhood experiences. So I did not say that being abused, neglected, sexually abused, having 15 different foster home placements, being victimized repeatedly for years is not harmful, because it is. Next slide. I'm amazed that I have to have a slide like this in 2022. NFASD outcomes are dependent on the timing and quality of the services. It's the treatment, not trying harder, that counts. It's the treatment. Next slide. So, just a little tour through FASD. Often starting off in infancy, low muscle tone or rigidity, difficulty eating, insatiable eating. Can't get them to wake up, they won't sleep. Night terrors, snoring, apnea, sleep's a big thing. Eating disorders might be evenly split between FASD and adverse childhood experiences. But wow, so many kids getting up in the middle of the night, eating till they get sick, then eat some more, hiding food, taking food around the house, hearing loss, visual impairment, very common, speech and language disorders. By the way, speech and language disorders are one of the most important interventions, in part because of the effect on cognition and the behavior management that goes on to getting the kids to come in there, sit down, and do their work. Cocktail speech is big. They're trying to explain something to you. You listen to them. It's not clear at all what they said. There's a lot of difficulties with language in FASD. We're just starting to understand this now. Very low rates of oral comprehension, high rates of confabulation, gullibility. They're just often people with high degrees of vulnerability. Many of these people are often more aware of some of these issues than they are other things. I just have a lot of bad stuff to say about our current reunification policies. So I see kids often who a day or two before a home visit can't sleep, lose their toilet training. have to be carried, pushed into the car, carried, pushed into visit. So traumatized by this that often they can't walk out of the building back to the car. This is currently not well done. It needs a lot of improvement. People with FASD have a lot of social interaction deficits. Couple phrases from the mom, where's my mom? That was my third mom. None of those dads liked me. Next slide. When you think of the brain of people with FASD, you want to think of Christmas tree lights. You take them out of the box, you plug them in before you put them on the tree. Sometimes you get them on the tree, you look up and they've gone out. You wiggle them, some of them come on, some of them don't. In FASD, that's how your brain works. You knew your multiplication facts on Tuesday. Today, it's like you never heard of them. So when these lights go off, these strings of lights, say for attention or recall or memory or sleep or managing your temper, those are our impairments. One of the things I've been very impressed with is the tremendous toileting problems in this population. Sometimes these toileting problems last for decades. You pardon me for saying this, so if it's offensive, plug your ears now. One of my students one time had the wise observations. When you're treated like shit, it becomes a currency. And so pooping around the house, hiding your diaper, pooping in front of the toilet, anxiety disorders, learning disabilities, intellectual disability, very common. People who have been around folks with FASD can tell you that sometimes you ask them a question, they look at you and nothing is happening. No response. Sometimes they'll give you a random guess or an off-topic response. Abulia is very common. Motivational deficit. And they got the other things, the poor coordination, difficulties with temper management. On and on this goes. Just to give you some idea of some of the problems that when you look at a big population of these people that you see. Much of this not commonly reported because a lot of research facilities deal with a very narrow slice of FASD. Next slide. So remember, the brain is a lot like Christmas tree lights. In FASD, some parts, half the lights go off, sometimes all the lights go off. That might affect your attention, your memory, your knowledge, spelling words, multiplication facts, schedule. No schedule for weeks and weeks and weeks. One day you wake up, it's like you can't do it anymore. This is not one of these kids deciding to jerk the teacher around. So they didn't decide 2 weeks ago that this Monday, I planned this for 2 weeks. I'm going to fake not knowing my multiplication facts. Not how that works. Next slide. Every organ system one of the problems we have is that many of our diagnostic centers see a tiny little slice of people with FASD. They don't see very low functioning people who can't do neuropsych testing. So just to give you some idea of some of the health problems, which as you get, if you have FASD and as you're getting older, are going to become a bigger and bigger concern for you. Next slide. One of the moms that comes to see me painted this picture. Her experience as a parent. Her child had intellectual disability, undiagnosed, pretty severe mental health problems. The cause of this stuff was fetal alcohol spectrum disorder. Once we got this straightened out, got her daughter into a residential care facility, not short-term placement, long-term placement. Mom did much better. Her daughter did a huge amount better. Next slide. I'm just going to go over this quickly because I think this is one of the things that is misunderstood about FASD, and somehow we've got to get this fixed. 1-2%, could be more, require institutional care, severe health problems, feeding tubes, require oxygen, multi-organ system impairments. Another group that requires institutional care, fire setting, sexual predators, people with severe aggression. My opinion is that I don't anticipate these are going to change much. Care is going to be lifelong. Families participate, but don't do the direct care. Next slide. About 40% cared for by foster parents. Very expensive, full-time care. For many children, foster care is long-term. We always talk about it as though it's short-term. Changes in placement are frequent. At our center, the record we currently have is childhood 31 foster homes. Next slide. About 30% live with some combination of this. Parents, brothers, sisters, aunts, uncles, grandparents, or are adopted. Probably about 1 out of 5 of these kids is cared for by adoptive parents. Many of them go through most of their life stuck in foster care, with everybody thinking it's going to be short term. Really bad management to do that. Next slide. People need to know this when these kids are infants. Because this is modifiable. Next slide. The cream of the crop of interventions, developmental disabilities. I tell people in our state that if we can get your kid into developmental disabilities, they will disappear. We probably won't see them again unless we run into them when they're going to the movie. They're on their way to work. They're bowling, Christmas shopping, going out for pizza. Developmental disabilities in this part of the world is the cream of the crop for interventions. And why is that? Well, because DD realizes that if you have cerebral palsy and can't walk, they're going to accommodate. Get you a wheelchair, put a ramp in the house, make the house accessible, get a dial-a-ride set up to haul you around. They accommodate. They want to maximize performance, but they accommodate. And it makes all the difference. It's the Cadillac of care, as good as it gets. Next slide. So, what do we do with people who have these mega meltdowns, episodes of forest fire, explosion, outburst, storm, rages, whatever you want to call them? Well, if we look at it like this, these things start, they reach a peak, and then they go down. Often they start in elementary school. Management is so bad, they get much, much worse. So at the first sign of these, now, it may be that you're a person that likes having somebody throw chairs around, kick the walls, and scream in your living room or your classroom. And if you like that, you're in luck. If you don't, you should study how this works. And at the first sign, use distraction. This means quit what you're doing. Let me repeat that. Distraction. This means quit what you're doing. A second thing, perhaps somewhat more unique to FASD than other things. Talking makes it worse. Quit it. If talking helped, you wouldn't be watching this presentation right now. Don't be talking, change activities. Do something different. Homework explosion, quit. Homework, go for a walk, eat a Snickers. The further up you go on this, the more adverse talking is. We go into home, there's the 14-year-old sitting on the steps, hole in the wall, table turned over. Mom and dad are standing there. We walk in the door. The dad says, I've had it with this crap. This is the last damn time. I don't know how many times we have to put up with this. Every damn day we go through this. The kid's up there crying. So we say, okay, you guys go in here, close the door, get some coffee. Better yet, go sit in your car, listen to some music, call your sister. We get the child calmed down. The parents can't contain themselves. Back in they come. And by the way, did he tell you about the problems he had at school? I don't know how we're supposed to put up with this. And it starts all over again. Talking, rarely helpful when it comes to these kinds of episodes. Now, you can do it. It might make you feel better, but there's no compelling evidence it's going to help. Way better to do something different. Get out some Mountain Dew, Diet Dr. Pepper, go for a walk. Once this thing's over, unless you want to go through it again, don't talk about it. What we do instead is we start a positive behavior management program to reward positive behavior. Next slide. So I think it's fair to say that people with developmental disabilities can be complicated. Sleep problems often persist for many years. Eating problems might require ongoing management. Often getting better, about the time elementary school, you get into elementary school. Toilet training difficulties, you need a schedule for this. You have to have a schedule. In this population, sometimes these toilet training problems literally last for decades. Temper management, temper tantrums in a 2-year-old, 4-year-old, much different than temper tantrums in a 16-year-old, 20-year-old. Need a lot of developmental therapies. Schools, almost all parents welcome school. They have a little time off. Homework, pretty much a terrible idea. If I was going to summarize this in one word, I'd say don't. don't. And you want to be aware, this is not a condition that typically gets better over time. It gets more complicated. Doesn't mean the burden is that much greater. It just needs, you need to have thought about this and done some planning. Parents need some time off. They have to have some time away. Otherwise, we just burn them out.
So Dr. Bird, we've got several like really good questions and I don't want to run out of time.
Let me stop there and I'll answer questions.
Okay, so John's asking, does this mean even therapy sessions discussing behaviors will not work for these children?
What would be an example?
John, you want to come off mute for just a second?
Yeah, so just for example, we had one placement that unfortunately had multiple homes like you're describing throughout this presentation, but other issues as well. However, you know, every therapy session, anytime you would ever talk about behaviors, did exactly what you're talking about. It was almost like it was it was just like throwing gasoline on fire every time. And we had intensive home therapy for over 6 months. Every time that was over, talking about the issues, talking about past, even play therapy for that matter, would like flare things up. So I was just wondering if, is that something?
I can give you a way to check this out. Take a sheet of paper, get a cup of coffee and write 20 things on it that your wife needs to change to be a better wife and mother. Follow her around the house reading these to her. See if by the time you get to number 4, you haven't discovered that she has a similar list of things you need to change. And the longer you go through this, the worse things will get in your house. One episode of this could affect your relationship for a couple of weeks. Or take that sheet of paper and write 20 things about her. Start with things like this. You're the treasure of my life. The greatest thing I have ever done was marry you. I cannot even tell you how much you've improved my life. Sometimes when I get to thinking about you during the day, I can't concentrate on anything else for 20 minutes. Read 20 of those to her and see what happens. Kids with FASD are just like that, right? You start on your problem list, they're not going to react well. What we want is more positive behavior. If you think of a teeter-totter, on one side, negative behavior, on the other side, positive behavior. As negative behavior goes up, positive behavior goes down. We want to be on the other side. As positive behavior goes up, negative behavior goes down. We want to focus on positive behavior.
Yeah, and Dr. Bird, I think this is where the school systems fail because they try to put these kids on their traditional discipline plans. And so when you have a big incident at school, it's like, oh, it must be consequenced. It must be consequenced. And we begin losing our kids. It's just another person pushing them away. And I mean, we could go on and on about that, but especially our kids with FASD, what is a way that the school systems could come across this? Or what is a way that we could advocate for our children to be treated in the schools? 2
pamphlets associated with the booklets. Booklets would be a better term. One, a booklet called Changing Behavior. And it has a positive behavior management strategy, I think on page 2 and 3. A second is FASD for educators, or I forget the title, but we made that just for schools.
So did you also do the Changing Behaviors booklet? Because I know you were okay. So both of those are going to be on his website, and I can pull it real quick and drop it so you guys can see that. Another question that came in was more books for just foster parents and adoptive parents, and like the viewpoint of them. Would you say the same books or different?
So if you want to spend your time on something, husbands, take your wife out for a date night. Wives, take your husbands out. Get some time away. This wears you down.
Agreed.
Use some respite care. Second, join the support group. But only join the support group if there's an agreement that people cannot tell long stories. Nobody wants to hear somebody talk for 20 minutes, recounting all the difficulty they've had since infancy to placement in the correction system for a 25-year-old. Instead, what we want is simple solutions. For sleep, you want a picture schedule. For the morning, you want a picture schedule. If these schedules work, you don't have to. Let me repeat that. If you have a morning schedule, get out of bed, brush your teeth, go to the bathroom, get dressed, come downstairs, eat breakfast. You don't have to do that once the child learns how to do it. Now, they may be a long time before they can do it without the pictures. But if schedules work, you don't have to. And you want two of them, one for going to bed, one for getting up in the morning.
Good point. So the next question we have is, what are key simple talking points for frontline social workers and what they should know about FASD?
That's what they do for a living. Yeah, I mean, they are a substance abuse treatment program. They may think it's trauma, they may think it's low IQ, other stuff, but it's mostly substance use. And they need to get better at that.
Okay.
And they need to just figure that out.
Can we use the last few minutes jumping in and interventions? Because as a foster parent with children in my home with FASD, I mean, this is where the meat of it is. Once you understand, now what?
Well, but I think it's the understanding that is the now what. You can be seeing people who want to talk about positive stuff. The school every day, oh, he is such a delight to have here. It's so, I can't tell you, he gets along so well. And then in April, they say, well, I think we might have to retain him. Almost every day we've had difficulties.
Right.
He's 2 grade levels behind in reading. This is ridiculous. So for people who are involved in the management of this, you have to have respite care. You have to have time off. You cannot do this without time off. It's too difficult. Positive behavior management is the key. Understanding that much of this is impairment. It's brain damage. It's not behavior. Focus on increasing the amount of positive behavior. It's like a seesaw, teeter-totter, whatever we call it. As positive behavior on one end goes up, negative behavior on the other end goes down. There's a booklet, Diagnosis Informed Care. I think it's part of the packet of stuff we sent for you, but I think it'll be helpful. But remember, going through here, we've talked about 5 or 10 different problems and how to approach this.
So we've got like 2 more minutes. Are there any other last minute questions that you want to ask? And then the other thing I want to mention is that we recognize that the support group is very imperative to have. And so we're launching a statewide support group. So make sure you're following us on Facebook, make sure that you're signed up for our emails, and you can get there through our main site to sign up. Just make sure you're there, you're in there, and I will send that out. But we have someone who is going to lead those sessions. It's going to be a year-long program. It's going to be very research-based information given to you. Each session you'll learn something, you'll be able to connect and those kinds of things. We appreciate you guys being here. It's so imperative that we get this information out. In a few days, this actual recording will be up on our YouTube channel, and you'll be able to pull it from our Facebook page. So want to make sure that if you want to share it with your social workers, if you want to share it with your child's teacher, it's there for them to look at. And Dr. Bird, I can't thank you enough. You shifted my thinking, and I think there's multiple people here whose thoughts have definitely shifted today. And I look forward to connecting with you more and doing more with State of North Carolina.
Appreciate it. Thank you. Have a great weekend, everybody.
And by the way, Dr. Bird, the weather here is much nicer than North Dakota. When you were telling me how long it stays, I mean, just frozen, no way. And guys, make sure those of you that are still on, make sure you fill out the questionnaire that came to you. It'll be sent to you.
I did have a quick question.
Okay.
I was several minutes late getting logged on. I had trouble. Was there any kind of check-in thing or?
So the system that we're using tracks you. And so I'm able, you don't have to do anything. It just tracks you. If you will, make sure to fill out the evaluation, because if you don't, then I'm gonna hunt you down before I send your certificate, because we do want to know, the feedback and that kind of thing.
Yeah. Well, is that something that will be sent later? Because I didn't get the email to.
Yeah, I will make sure Erica will be resending it. I'll make sure she does that.
Okay, thanks.
Thank you, guys.
The evaluations are also in CVent. So if you don't see an email, you can check there too.
Yes, thank you, Kate. So back out on the main page before you clicked in the session, there'll be evaluation there.
Okay, thanks.
Thank you, Gail. Thank you, guys.
Thanks, Jessica, for coming. Thanks, Jonathan.
Thank you.
Thanks, guys.
Yeah. Thanks, Kate.
Thank you.
All right. Well, I am going to log off and go get some lunch. I might have a quiet house, I think. They went to the pumpkin patch. So bye. I'll see you Monday, or I'll talk to you Monday.